Okay, well, welcome everybody to the APNA Chronic Disease Management Healthy Aging Program Pain Management webinar. My name is John Hardgrove. I'm a project manager here at APNA. This webinar has been produced as part of the Chronic Disease Management and Healthy Aging Program. And for more information on that, you're welcome to visit our website for more. I'd like to start with the acknowledgement of country. I'd like to acknowledge the traditional owners and custodians of the land and sea on whose lands we work and live. We wish to pay our respects to all traditional owners and elders past, present and future. We welcome you across Australia and acknowledge the many traditional lands wherever you are joining us from today. Just a little bit of housekeeping here. The presentation tonight will be recorded, and by attending the session, you agree to the recording. Presentation recording will be made available to you via YouTube. There'll be a link that comes out by email a couple of days after the presentation for those of you in attendance. So feel free to ask any questions tonight using the Q&A function. We'll have some time at the end to answer these questions and run through them, but you're welcome to leave your questions at any time using the Q&A function, and we will see to those. I would like to now introduce you to the guest presenters, Kathy Mitchell and Peter Sirocco, who will be presenting this workshop today.
Thank you, guys. Sorry, we'll just share our screen. Go. Cool. So here we're going to be talking about chronic pain integration and education of patients for primary health nurses as well. So got Kathy Mitchell as a nurse practitioner and myself as a nurse practitioner candidate, finishing my studies in the next week or so. So we're going to be talking about all things in regards to practice nurses and their role in regard to education and integration, and also surveillance and monitoring and identification of chronic pain conditions, treatments, and management options that practice nurses can advocate for on behalf of their patients. So over to you, Kathy.
Yeah, thanks, Peter. I'm Kathy. I'm a nurse practitioner. I've predominantly worked in general practice and have done a little bit of time working at Pain Med SA with Peter. So we're looking forward to sort of trying to give some tools to practice nurses and how to have those difficult conversations with patients about complex chronic pain. Okay, so basically, just move that across. That's right up there.
That's right.
Okay, so what do we know about pain? Okay, millions of Australians live with pain, and approximately 1 in 5 adults have chronic pain in Australia. Chronic pain affects more than 3 million people. It's common, in particular, people who are over 65. There's a 1-to-3 ratio. And 68% of people living with chronic pain are of working age. Up to 80% of aged care residents live with persistent pain, which is often undertreated and poorly managed. We know that the pain burden is growing. And it's estimated by 2032, the number of cases of arthritis and other musculoskeletal conditions will increase by 43%. And it will probably affect over 30% of the population. So chronic pain is associated with other health conditions and mental health disabilities. Other comorbidities such as depression, sleep disturbance, fatigue are very common among people. And this is often debilitating, and it has adverse effects on work, functioning and relationships. And I'm sure you see that in your roles. There's high rates of generalised anxiety disorder, post-traumatic stress disorder, substance misuse, and also are also reported with people that have chronic pain. We know that the suicide rate is 2 to 3 times higher in those suffering with chronic pain compared to the general population. There's low awareness of pain and its treatment options. Awareness of pain and pain management is low among health practitioners and consumers. People don't understand it. Challenging beliefs about pain and its treatments is critical to build resilience in patients and producing more effective health outcomes. And explaining the neuroscience of pain has been shown to improve pain and movement and reduce the fear avoidance. There's a reliance of pain medications. And a 30% increase in opioid prescribing occurred between 2009 and 2014. We know that it's a problem. Opioid medications have been prescribed in some areas at 10 times the rate of other areas, and that's in regional areas. Rising numbers of Australians are dying from accidental overdosing from prescription drugs. And the rate of opioid-induced deaths almost doubled in 10 years, from 3.8% to 6.6 deaths per 100,000 Australians between 2007 and 2016. And that number is escalating. More than 3/4 of all drug deaths involved pharmaceutical opioids. I'm just going to talk to you about the different types of pain, just so we can differentiate. Acute pain, we know, is time limited and a response to a trauma or other noxious experience, including pain related to medical procedures or acute medical conditions. Subacute pain is usually pain categorised progressing towards chronic pain, but it may be prevented. And there examples of that are like people that come in with acute wounds and they progress into chronic wounds, and hence they end up with a chronic pain because of those. Recurrent pain is pain that is, for example, like migraines or period pain or those sorts of pain that comes and goes. We've got chronic non-cancer pain, and that's usually pain that's longer than 3 months, and it doesn't change, it doesn't get better, it doesn't go away. And then we have cancer-related pain, which is managed differently to acute pain.
So for the chronic non-cancer pain as well, it's important to ascertain that it can be 3 months of essentially a plateauing in pain location, type, and sort of severity as well. So it's important to disseminate between those kinds as well, as Kathy was talking about. So in regards to the 3 types of pain, there's, on top of that, there's different types. And we've got the nociceptive, the neuropathic, and nociplastic pain. So in regards to the nociceptive pain, that's damage to any sort of body tissue that's sharp, aching, throbbing pain, and be caused by a whole bunch of things. A lot of the times it can be more of a surgical type of pain that has turned into a chronic sort of pain in regards to wound beds, etc., that sort of thing, as Kathy alluded to earlier. And also injury, surgery, arthritis, osteoporosis, and musculoskeletal conditions too. So usually, your breaks and that sort of thing of bones, etc., is attributed to a nociceptive kind of pain. Neuropathic pain is damage to the nervous system itself, and that can happen all sorts of things. A classic example is burns patients, that sort of thing, where you're actually having damage to the nerves, but the tissue as well. Sensations can be described as burning, shooting pains as well, and they can be described as numbness, tingling, or overall sensitivity or allergenic response. And then you've got your nociplastic pains, and that's related to an increase in the nervous system sensitization rather than to tissue or nerve injury. And there's no real evidence of actual threatening tissue damage itself. And those nociplastic sort of pains can be all sorts of conditions, including things like complex regional pain syndrome, etc. So in the next slide, we just go through the different kinds of pain here too. So we've got the musculoskeletal pains, and as we described before, that's your osteoarthritis and those sorts of muscle or skeletal related pains per se. And then next, the visceral types of pain. Now, the visceral types of pain, I did ask Kathy what on earth this is here, and of course that's your renal calculi, your kidney stones as well. Very painful. So they're the sorts of visceral pains, but that can be attributed to breathing and all sorts of just normal body habitus functions, including bowel function or gallbladder pain and that sort of thing, but also period pain as well is a type of visceral pain because that's a normal body function that causes an abnormal pain response. And then finally as well, we've got the neuropathic pain as well. You can see here this patient's got quite a large shingles flare here as well, and that can develop into a post-hepatic neuralgia type of pain, and that's a neuropathic pain. And as we said, that's a burning type of pain where it's quite painful in regard to response. Now, on the next slide here, and just so you know, everyone, we'll be able to take questions at the end too. So if you do have any questions, let us know, write them in the chat, and we'll be able to go through them at the end. And the two of us and John will go through those at the end too. So here we have an excellent video that we're going to go through in regards to neuroplasticity. It's just a 2-minute video that describes neuroplasticity and, you know, the weird and wonderful in regards to brain function and things to explore there, and also chronic pain responses therein.
Not so long ago, many scientists believed that the brain did not change after childhood, that it was hardwired and fixed by the time we became adults. But recent advances in only the last decade now tell us that this is simply not true. The brain can and does change throughout our lives. It is adaptable, like plastic. Hence, neuroscientists call this neuroplasticity. How does neuroplasticity work? If you think of your brain as a dynamic, connected power grid, there are billions of pathways or roads lighting up every time you think, feel, or do something. Some of these roads are well-traveled. These are our habits, our established ways of thinking, feeling, and doing. Every time we think in a certain way, practice a particular task, or feel a specific emotion, we strengthen this road. It becomes easier for our brains to travel this pathway. Say we think about something differently, learn a new task, or choose a different emotion. We start carving out a new road. If we keep traveling that road, our brains begin to use this pathway more, and this new way of thinking, feeling, or doing becomes second nature. The old pathway gets used less and less and weakens. This process of rewiring your brain by forming new connections and weakening old ones is neuroplasticity in action. The good news is that we all have the ability to learn and change by rewiring our brains. If you have ever changed a bad habit or thought about something differently, you have carved a new pathway in your brain and experienced neuroplasticity firsthand. With repeated and directed attention towards your desired change, you can rewire your brain.
So now over to you, Kathy. So we'll come back to that in regards to the neuroplasticity side of things for a case study that we'll go through later.
Yeah. So next I want to talk to you about is what we call a biopsychosocial model of pain management. And many of you have probably heard this term before, but what does it actually mean? And what it means is managing a patient's pain as holistically. It's a whole person's approach. So in many cases, we know that there's no definitive cure for most chronic pain conditions. The goal is to manage the patient's pain, restore their physical and emotional functioning, and improve their quality of life. So let's break this up and have a look at what the components are. Biomedical includes managing patients' pain by surgery, nerve blocks, or medication. There's also more invasive medical procedures such as spinal cord and peripheral nerve stimulators, which are used in pain clinics. Commonly used medications include anti-inflammatories, paracetamol, antidepressants, anticonvulsants, and we use opioids. It can also include pharmacological treatments for depression and anxiety. The psychological treatments include the cognitive behaviour therapy. And this helps the patient to address patterns of thinking and behaviour. And keeping in mind when we're talking about this is the previous clip on neuroplasticity. Goal setting, development and planning with much emphasis on accurate understanding of pain and its relationship between the physiological pain and muscle tension, thoughts, emotions and behaviours is all important. Lifestyle changes and strategies to improve sleep patterns and develop better coping skills for pain and other stresses using various techniques. For example, pacing activities and relaxation, meditation, and so forth.
So with the psychological side of things, that's something that can be often missed in regards to chronic pain management and integration of care plans, etc. And from a practice nurse point of view, it's a fantastic thing to sort of engage a patient in with, and whether they've had any engagement with that at all. It'd be something that can be absolutely fantastic for these cohort of patients as well, and treatment options. It's something that's quite good.
So the social component, this involves exercise programs or therapy by a physiotherapist, exercise physiologist, occupational therapist, or social workers. And this could include a progressive program of range of motion therapy, muscle strengthening, and postural training. Any therapy utilised will also include like promoting active self-management strategies to increase the patient's ability to work and function, improve their household duties, their activities of daily living, and simply enjoy their life. So a lot of this times we're focusing on improving function and not so much as reducing pain. Yeah. Patient-centred, it needs to be patient-centred and involves a multimodal approach. That's what we say, multimodal, meaning a number of different types of management, and by a multidisciplinary team. Yeah. When we're dealing with chronic pain, we have to involve all of those people. It's not just a one person that you can't manage chronic pain with one person.
And with the social side of things as well, it's important to identify patients that, have some sort of social phobia, etc. There's all sorts of community-based activities, especially in our older populations as well, of things to engage with counsel, etc. Just a generalised activity. A lot of the times, patients that we see in our clinic, and you may see as well, in regards to engagement with any sort of community-based activities or just general exercise activities that may be available for access, it's usually hasn't been engaged or they're not aware of it. So anything that's in the community in regards to engagement and just some sort of consistency in activity is often the key here. So that's something that can be encouraged too. So, yeah.
Okay. So this next slide, I just want to go through this with you. And I often print these slides off and use these as tools and ways to explain to people how pain works. And this is one of the toughest tasks, to have that conversation. It's difficult to talk to people about pain, but you have to be able to communicate that across in words that the patient understands. So pain, when we go through, pain has a very important function. It's really vital for our survival. And when we have something that causes pain, that's a warning system that's sending messages from the receptors up to the spinal cord and then through to the brain, which lets us know that something needs to be done. It's useful to be able to explain to patients how the pain pathways work and that they're regulated by filters or gates. And these change the amount of information coming from the receptors up the spinal cord and towards the brain. These gates control the amount of information so that the brain doesn't overload with information. So generally, if pain signals are really high, then the gates in the spinal cord and the brain will be able to receive and recognise that something is there that needs to be addressed. This is the body's warning and protective system. So for acute pain, the messages go up the brain from where it's causing the pain, but the gates in the spinal cord work very well. And if we give something like a strong medication, like morphine or something like that, we can close the gates and turn down the volume of the pain, and the control is quite well. So with chronic pain, the gates are much harder to close. And so the normal sort of treatments that we might use for acute pain, even strong medications, sometimes are not successful in relieving the pain. Hence, we need to use other approaches that help us to manage the chronic pain more effectively. What we know is that there are pathways that come down from the brain, down to the spinal cord, that control these gates in our nervous system by releasing excitatory or inhibitory chemicals. The excitatory chemicals like glutamate, bradykinin, substance P, usually open the gates and turn up the pain. The inhibitory chemicals, such as the endogenous opioids, serotonin, noradrenaline, or GABA, they work on closing the gates and they turn down the pain volume. And we know that thoughts and feelings change these pathways and they release excitatory and inhibitory chemicals. So, for example, if we're tired or stressed or anxious, the excitatory chemicals are released, which open the gates and it increases our pain. It turns up the volume. But if we're calm and relaxed, then the inhibitory chemicals are released, which actually close the gates and reduce the pain. So our thoughts and our feelings are very important in terms of how we experience pain. And these are important concepts to understand and be able to communicate across the patients, because when you start to talk about relaxation and psychologists and all that, people become very guarded. You're very guarded to think that, you're saying it's all in my head. So you've got to be able to explain this in their words.
Yeah, so the way that we describe it in our clinic is you've got medical treatments, cognitive treatments, and physical treatments. You know, you can have all the medications in the world, but that's not going to help with your mood and your physical ability. You can, go do physical rehab and do all the deadlifts in the world, that sort of thing, to strengthen your back. But you may have some sort of pain sequelae that is managed by medications, and the psychological impacts. You know, you can do cognitive behavioural therapy, and you can do all the pacing and chunking and other stuff like that in regards to cognitive strategies, but there still may be an underlying thing. So all in moderation is the key here. And that's something as practice nurses you can advocate to the patients. And a lot of patients may not have heard that approach before, because they may be seeing it as purely a medical focus or a pharmacotherapy focus as well. So moderation is the key here for all of those aspects, as Kathy was saying. So yeah, it's something to explore with these sorts of patients.
So what does it all mean for treatment-wise? The balance between excitatory and inhibition is dynamic, and it can be altered in different behaviours, emotional, psychological. Descending pain pathways, they play a critical role in determining both experience of both acute and chronic pain. We know the concept of neuroplasticity, as we've seen in the clip, and how the brain and the nervous system constantly changes, and that there's ways to retrain the brain. So if you like, to reduce the amplification, to turn down the pain volume. And these include exercise, relaxation, distraction, meditation, diet. We know that all of these are helpful for dealing with pain. And it's really one thing that's going to do the trick. It means looking at all of these things, finding out what works for the patient, and then encouraging them to put these into place. Patients need to be reassured that they're not alone in managing their pain. There are people around them. It may be friends, maybe family, but also their health practitioners. And it's good to include them in whatever they're doing, and maybe develop a plan about how they're going to move forward. This is particularly important when we're weaning medications such as opioids. People feel very frightened and very alone at the thought of someone's going to take my opioids away. So in one hand, as we're reducing opioids and medication, we have to be giving something back with the other hand.
Correct. And I think with these sorts of patients, when you're talking with them, a lot of the times, either as a practice nurse or even in our roles as well, working in specialist outpatients for chronic pain, a lot of the time it's the first time they've been heard. You know, they've seen multiple providers, multiple specialists, and they're just wanting to know the what next and the what other. And that's where your role as a practice nurse is of huge importance, not just for advocating, but just educating the patients for this sort of thing. And the other thing too, in regards to the not feeling alone, I think that's something that you can talk with your patients about, is that you're not alone. It's something that everyone experiences, and something you can go through. So in regards to opioids in the community, and in regards to, I guess this goes on to the first slide as well, and extends on to what Kathy was talking about before in regards to prevalence of chronic pain and opioid usage. Now, I'm sure everyone's seen the use of the usual algorithm of Panting or endone, either for acute or chronic pain as well. But the prevalence for chronic pain, 15.4% of the Australian population over the age of 15, and of course it increases with age as well. Now, the prevalence of chronic pain between the urban and regional areas, according to the Cost of Pain in Australia, that was done by Deloitte and Pain Australia in 2019, I think. It's about the same in regards to prevalence of chronic pain, but the usage of opioids in the rural communities is a lot higher compared to urban on a per capita basis. That can be for a multitude of factors as well. It can be due to lack of access, lack of experience or education in the areas in regards to their knowledge of medical strategies, and also access to medical treatment options as well. And of course, one thing that can be discussed from a practice nurse point of view is, of course, the risks of long-term exposure to opioid therapy. And the two key ones that we like to discuss with our patients is your vitamin D and testosterone levels. So long-term exposure to opioids can decrease your vitamin D levels as well. So that can impact, of course, on your bone density because it affects the metabolism of vitamin D, and therefore it affects the metabolism of your calcium to make your bones nice and strong. So bone density can be affected there too. And also your testosterone level as well. Now that's for males and females, of course. There's all sorts of issues that can happen when you've got a hormone changes or hormone imbalances, including hypogonadism, erectile dysfunction, impotence, and sexual dysfunction as well. And they're the sorts of things that patients may be fearful of discussing at large as well. And that may be something after you discuss it with your patient and sort of go through it with them, is they may be more privy to discuss that with you, and that can be treatment options to discuss as part of the multidisciplinary team. So, of course, it's the what next in regards to opioid therapy and how you go through the management of that. And that's a part of the 6 A's as well. So the 6 A's are your activity, analgesia, adverse effects, aberrant behaviours, effect, and accurate records. And of course, what are all them? So you've got your activity, and that's basically what progress can be made for the patient's functional goals. So the key here is you're on opioid therapy, but what are you looking to achieve in regards to minimising your pain? What do you want to get back to? Is it so you can sit for longer, so you can stand, so you can walk, and activity to perform activities of daily living? A lot of patients who are on long-term opioid exposure, they may be fearful for their medications to go. But at the same time, it's about what can they return to doing previously, like I was saying before. So in regards to the activities of daily living, what are they limited from doing now, even with the opioid therapies? And what do they want to get back to? So a lot of times it's discussion about hobbies or activities that they enjoyed previously, that sort of thing. The analgesia side of things. Now, how does a patient basically rate their pain on 24 hours? So basically, we all know about the visual analog scale of 0 to 10 out of 10, 0 being no pain at all, 10 being the worst pain in the world. We usually ask that over the last 24 hours or 7 days, depends. And how much do those medications help with your pain relief? And this doesn't have to necessarily be opioids either. This can also be your anticonvulsants, like usage of Lyrica, which is very high in the community as well, and how much relief you get from those medications. And the next part, which is important, is the adverse effects. Do they get any adverse effects from the medications? Now, the usual constipation, which can happen from long-term opioid exposure, is a big thing, but nausea, dizziness, drowsiness, foggy brain, that sort of thing that patients can describe, is that a consequence of the medications, or is there something else that's underlying there? Aberrant behaviours. Is the patient taking the medications as prescribed? Now, a big thing here, especially for immediate release opioids, or such as your endones or patenting forts, are they using it more than prescribed or indicated? And have they had any problematic behaviours in regards to medication abuse or misuse? Now, there's ways of monitoring that. For example, in South Australia, there's script checked SA. That's only accessible, I think, at the present time to prescribing practitioners, but they may be opening up in the future. But there's also access to My Health Records, that sort of thing, to see dispensing records, that sort of thing, to see, is the patient using it more often, or are they even using it at all? It's something to keep an eye on. Unsanctioned dose escalations and drug and alcohol use as a concurrent thing, or even concurrent use in regards to use of benzodiazepines at the same time. For example, diazepam or Valium is a big thing here. And as a patient reported, lost prescriptions or repeated early repeats too. So doctor shopping, that sort of thing is something to keep an eye on too. Has the patient had any changes to the way the patient's been feeling? Is it impacting on their mood? Is the patient depressed or anxious? Is there sexual dysfunction? That's a big thing. And one of the big ones here is the usage of tramadol. Tramadol can have a serotonergic response. So highly encourage you to have a look at serotonin syndrome and the effects from that. Tramadol has an increased risk of that. But any opioid, and it's not really dependent on their dosage, can have that effect as well. And of course, accurate records as well. So from the initiation of the therapy of the opioid itself, of how things are going and how the follow-up is. And the key thing is pain is subjective, okay? It's different for everyone. Everyone has a different experience and a different response. But to use an objective record like FAS score and also percentages of relief from there help to at least normalize, or so we can know what the patient's response is from that. And any changes in the management plan as well. What other effects or impacts are they having? And also, what else is the patient doing in the background as well? And that can be, you know, physical therapies or cognitive therapies, or even, you know, boom bust cycle sort of activities where they're doing way too much and then not able to do anything at all. So the next thing that I like to do as well, we talked about keeping things objective in regards to a subjective thing such as chronic pain, is a use of a handy little app that I love, and that's called the Opioid Calculator. Now, I'm not sure if anyone's seen this one, but it's one that I love to talk to, even with patients as well, where you can actually go through and basically calculate what the oral morphine equivalent daily dose is for patients. And it's irrespective of what opioid they're on. It can be codeine, it can be buprenorphine or a Norspam patch, tramadol, oxycodone, that sort of thing. It normalizes it to a morphine equivalent daily dose, so we can see, one, how much they're getting, and two, what their risk factors are. So anything, any sort of exposure over 50 milligrams of oral morphine equivalent daily dose a day puts them in a high risk category, and anything over 100 milligrams is extremely high risk too. But I've just got a screen recording from my phone. And this one here, basically, now excuse me if you see a couple of apps like Snapchat, so ignore that one, but it's an app for the opioid calculator. If you open the calculator, this is one for a case study that we're doing very soon. So it goes through the oral, sublingual, transdermal, which includes your Norspam and parenteral preparations for injections, etc. But on this one here, for this lady, she was on 100 milligrams a day of oxycodone. So if you calculate that one, you can see here that even though she's taking 100 milligrams, that gives you an oral morphine equivalent daily dose of 150 milligrams, which is quite high. And obviously that sort of rationalizes it, where the patient can say, okay, that's how much I'm on, what's the next goals? And even rotational therapies, etc., is something to consider there. So that's one I highly encourage yourself to download, more from an educational point of view, but also for patients to just go through and see, okay, how much am I on? Because even taking a high amount of codeine as well puts you in a very high category as well. So obviously, in regards to that, it's a good educational tool. So next we have a case study, Carol, and it's one that myself and Kathy have talked about previously, but it's an interesting one in regards to Carol will just talk about the treatment options there. So,
okay. So the good points with the medications, and don't forget, when you are looking at patients' overall medications, consider the home medication reviews. Patients with polypharmacy that are on lots of medications, get the GP to do a home medication review. Yep. It's all about safe prescribing, and equate those a daily dose of morphine and write it in your notes. Bring it to the GP's notice. Hey, look, your Mrs. Bloggs is on the equivalent of 150 milligrams of morphine a day. That's probably a little bit high. it's okay to challenge those things and advocate for your patient. Yeah. So let's talk about Carol. Carol is actually is actually a true life case study, believe it or not, that comes through the door in a general practice setting.
We did change the name.
We changed the name, yeah. So Carol's a married 57-year-old lady with 2 adult sons and 2 grandchildren. She has a history of lumbar spondylosis and lumbar disc protrusion with bilateral radiculopathy in her feet, both feet. Right side total hip replacement due to a ganglion, which was unsuccessful in relieving her pain. She had a left side total hip replacement following a fractured femur, and that was following a fall. And that gives you some idea about the risks of osteoporosis, because Carol certainly had osteoporosis. 2 laminectomies at the lumbar levels. Both were unsuccessful in relieving her pain. She had the operations and her pain didn't change. Comorbidities include major depression, anxiety, and she disclosed during the consult that she'd had suicide attempts. She suffered from insomnia, poor diet. She lived on coffee and Scotch finger biscuits. She had urinary incontinence, which wasn't related to the actual pain, but she just simply couldn't make it to the toilet in time, and she needed help to get on and off the toilet from her husband. Carol walked with a stick, and she had an ataxic gait. She used to wake 3 to 4 times a night. She was totally dependent on her husband for most of the activities. She was not intimate with her husband, and this is another discussion with people that they don't tend to want to talk about. But that was affecting her relationship. She felt very guilty that she wasn't able to be intimate with her husband. She'd given up a driver's license, which she couldn't go shopping. She rarely left the house. The GP surgery was her only outing. Her K10 score was 38, and she had severe symptoms of depression. There was no doubt about that. She was a smoker, 30 a day, and she wanted to quit. And she had a history of opioid dependence. And at that time, she was on OxyContin 100 milligrams a day. She was on duloxetine, 90 milligrams, mirtazapine, 45 milligrams at night, Lyrica, 150 twice a day, and valproate. And the OxyContin dose was a lot higher before we'd actually seen her. So this is the sort of patient that you look at in a 15-minute consult or a 10-minute consult, and you go, where do I start? And how do I manage this? And as nurses, I've got to try and do some planning for this lady to sort of assist the GP, because you're certainly part of the team. And I want to share with you next is a tool that you can use. And this tool is actually called a formulation. We call it Formulation. And it's actually, and it looks a little bit busy at the moment, but just bear with me. We'll go through this. So, and I use this as a template with patients that come in, and it's a way in which you can explain to them visually about how chronic pain presents and how you can manage it. So, at some time in Carol's life earlier on, she had, can I put the pointer on that one? At some time, Carol had an injury, that resulted in some nociceptive mechanism. She had spondylosis, disc protrusion, fractured femur, and ganglion. All of these things happened some time ago, and they all healed. But what was left, that meant that there was changes in Carol's central nervous system, and she developed neuropathic pain and neuroplastic mechanisms, and she had sensitization. All of this was the cause of Carol's pain. But what that meant was that because of the chronic pain, she had reduced activity. She couldn't work. She couldn't exercise. Her activities of daily living were interrupted. Because of this, she started to experience these physical deterioration. She had muscle wasting. She put on weight because she wasn't active. She had an ataxic gait. She walked quite abnormal. She needed a stick. She had a fear of falling, and she was incontinent of urine, which is a big problem for her when you're 57. All of that basically increased her excessive suffering and disability. But what it did also was it increased her depression. Her depression, helplessness, frustration, anger, anxiety, poor sleep, and she was a suicide risk because of all this. When this starts to happen, this feeds back over to the reduced activity, work, motivation was low. She didn't want to go anywhere. She didn't want to exercise. Basically wanted to sit home and on a lounge and sleep most of the day. This continued then on. It's
a vicious cycle.
Like I said, and we started to see. You start to see we've got a bit of a triangle going on here. So this feeds off of this. This feeds off of the lack of exercise, the body decompensation. Then what happens is that you start to develop these unhelpful beliefs and thoughts. That's what we call them. Catastrophizing. What's going to happen? You know, what's going to happen to me in future? Fear avoidance. I can't do this because it'll make my pain worse. Pain had destroyed her life. She was angry. She was angry against the GP, forgiven of the opioids. So now she was dependent on them. She was angry at the specialists. They didn't fix her pain. These operations should have fixed the pain and they didn't. That fed back over to, it made her depression and helplessness and frustration worse, the anger, the anxiety, all of this, which just caused excessive suffering and disability. So with that, when you start to have this happening, you can see how this feeds into the first step, reduced activity, no motivation to do anything. It increases the deterioration and so forth. You start to see the pathways. Repeated treatment failures, total hip replacement. She'd had 2. Internal fixation of a fractured femur, 2 laminectomies. She'd had steroid injections, epidurals, physio, medications, and repeat diagnostics. She was looking for answers, repeat scans, so forth. Nothing was coming up and nothing could help her. And again, that just exacerbated the psychological trauma that she was going through. The long-term use of opioids, sedative drugs, interactions with other medications, okay, that fed over to opioid dependence. She was now opioid dependent, and guess what? She still had the pain. The opioids weren't helping the pain at all. She had constipation, she had problems with falls, she was over-sedated, she was drowsy, and all of those things, again, feed back into the psychological symptoms that she was having, and again, they feed back to all of this. You can see how they're all linked in here. The loss of roles and her independence was a big issue. Loss of self-esteem. You know, she's wetting herself. She can't go anywhere because she can't get to the toilet. Family stresses, the dependence on her husband, deterioration of the relationship, financial problems, and she didn't have a driver's license anymore, so she was stuck.
She has a loss of role as well and a loss of self and everything.
Yeah, the loss of all. So now you can see that we're not just looking at chronic pain. We're not just looking at one area of chronic pain. This is the whole biopsychosocial model of pain. This is what it involves. And it's more than a quick fix. It's more than a medication. And this is what makes it so hard to get across to people. Input from family. And when we sit down and we have these discussions, it's really good to have the carer or the partner or somebody sitting. Most times when we start to sit down and we draw up this diagram, people will sit down and cry. They actually finally, someone understands what my life is like. So it's quite an overwhelming moment.
Yeah.
So let's have a look at how do we manage someone like Carol. Yeah. Okay, so it's about breaking it down, and now you understand why we involve a multidisciplinary team. You have to have lots of people involved in a patient like Carol. The first one was to get her safe. We needed to reduce her opioids. And when we started to do that, guess what? Her pain actually didn't get worse. It actually stayed the same. So she was actually able to offload some of the side effects that she was having from the opioids. We introduced relaxation and distraction to try and sort of that. We developed some SMART goals, and that was simply about what do you want to do? One of the things was she wanted to get a driver's license back. Okay, so we actually we drew up some goals on things that she wanted to be able to do. She wanted to go shopping. She wanted to do those simple things.
And if we put it back to the 6 A's as well in regards to that, you know, what do they want to get back to? What was their the term is pre-morbid capacity. So what are they able to get back to before the pain was there? And that's a key.
Yeah. So SMART goals were set, some pacing, some strengthening, some walking, exercises and social activities were all part of this. So before we could actually break this pattern, we had to sort of do some of these things. We had to involve the other health professionals, the psychiatrist review. We needed to look after our mental health, psychological support, some cognitive behaviour therapy, identifying and challenging the unhelpful thoughts when she was having this catastrophizing and so forth. The plan was also to focus on the pain smart activities. She wanted to be able to play with the grandkids. These were all things that we introduced. Continue the opioid weaning, ongoing collaboration with all of the people involved in the care. And then help her increase her activities to regain her confidence and her independence, improve her relationship with family and her husband. And then later, target the comorbidities with the poor nutrition and the smoking. So what does that look like when we all put it together? If we could break some of these pathways, we could fix some of these areas that were increasing Carol's excessive suffering and disability. So by introducing some of these strategies, we're actually able to sort of break this and improve her outcomes. Whilst that looks like a busy slide and there's lots to do, but if you don't map it down, and this is where it's very important when you're doing your care planning and your team care arrangements, your mental health care plans, all play a part. Patients with chronic pain like Carol, it's not just about managing one or two things or sending somebody off to the podiatrist or whatever. We look at all of these things. Correct. All of these things have to be implemented into the chronic care management. Let's just go to that one. Okay.
So this is the part of the GP and team care arrangements as well, and there's also mental health arrangements that can be done too. So obviously there's the Pain Network Health Plan 2, just about how you can go through some of the conversational strategies for these patients. Now, obviously, what I was saying before in regards to practice nurses, you guys will be the ones that can identify these patients, and you can see their progression throughout this sort of journey as well, about it's the first intervention versus where they are versus where they've been too. So it's all about, how can I start working on this today? Who can help me stay on track? How will I monitor my progress and what the next and what other is available? And these are the sort of preparation of GP management plan and the team care arrangement side of things. You guys may have seen these forms previously. There's also the GP mental health care plan, which can be flagged for the GP as well. So obviously it's about the role of the practice nurse and as an advocate and a liaison too. You are there and you guys are the primary focus and linchpin for a lot of practices, but obviously the awareness of pain and treatment options as well. So yeah.
It's about challenging the beliefs about pain and its treatments. It's quite okay for the practice nurse to have that discussion with the GP. Write it in the care plans. When you've got someone that's got a complex chronic pain like Carol, she's going to need a longer appointment. You can't see these people in 10 minutes. They need that time. So the nurses advocating for your chronic pain patients is very, very important.
Okay. So these are the take-home messages that we have for everyone today, which is there is science behind the pain theory. Now, chronic pain is a real thing, and it stems from an injury that either has healed or some sort of sensitization as well. But it is there. I think that's something that's important to acknowledge for these patients, that it is a real thing. The difference between acute and chronic pain is time and not necessarily severity. You can have patients that have a low severity in regards to pain, but it can be something that can be there for years or even decades as well, that the patient just thinks it's a thing. But at the same time, once that pain can be managed, they notice that they're having improvement to their activities and general function as well. So pain is subjective and individual to everyone, which we discussed earlier, and it's not visible either. Pain cannot be seen or imaged for most things. For other conditions like complex physical pain, yes, it can be seen and imaged. But long-standing chronic pain often has been investigated at that point. So in regards to red flags, usually they're not there, but it is important to ascertain if there are other changes, that sort of thing, to flag with the multidisciplinary team. The pain does not equal harm either as well. It's important to ensure that just because the pain is there, it doesn't mean that it is harming you or causing damage to themselves. That's something that is important to reinforce. The brain is plastic, the brain is ever evolving, and our knowledge in regards to our brain, it's always ongoing, and it can be retrained not to focus on the pain as well. And the goal is to obviously educate and teach skills to turn down the pain volume, as Kathy was talking about earlier, and improve coping mechanisms and generalized function. So we've just got some tools as well that we've gone through.
Yeah, just some useful tools. And if you go on to the ACI New South Wales Health Chronic Pain Management Network, it's got some fantastic tools on there that you can actually use. They're really good resources. If you haven't already seen it, look it up. If you do a Google on Pain Management Network, you will see it. There will be some very good resources there, and resources that you can actually use with your patient sitting in the room. So these are all available. And there's also a very good example of a GP management plan on this website. So it integrates the strategies for managing chronic pain. So that's a good resource that you could actually have a look at and integrate that into your other care planning and team care arrangements when you're doing the care plans.
Yeah, so also, if you have a look on the Pain Med SA website, we have some of the interventional approaches that we have as well, but we definitely encourage a biomedical model of care where it's multimodal and multidisciplinary too, and that's something that we highly encourage as a part of our clinic and role, etc. So that's the end of our presentation, but we're happy to take any questions whatsoever that people have, etc. I'll just stop sharing my screen, John, and yeah, any questions or anything else like that, I'm more than happy to go through them. So,
thank you very much for that, Peter and Kathy. I think that was a really informative presentation, and I know I took a lot out of it. We actually haven't had any questions come through yet, so if anyone does have a question that they were waiting to ask, now is your opportunity. Feel free to either use the Q&A function or the chat box just to put that in, and we'll happily see to it.
Yes. What I might discuss real quick is in regards to, I know we talked about pain specialists and access therein. That is something that obviously nationwide can be an issue in regards to access, timely access, that sort of thing, how we can access them, etc. And that's where our role is as nurse practitioners to sort of see and treat as required, but also to escalate and triage as well. So we're more than happy to take referrals both at our clinic and any other clinics nationwide that take these referrals, and more than happy to discuss it with practice nurses too. I do that frequently too, so any questions, more than happy to answer them. So yeah.
Great. We have had one quick question, if we'll be able to access the slides and a recording after the fact. We will be sending out a copy of the recording by emails. If you've attended this presentation, then you will get that email, both with an evaluation survey and a link to the recording. So that should hopefully suit your needs there.
Yeah. Excellent. Yes. So I guess I think the practice nurses, obviously, they're the linchpin and see these patients. You can see them on a day-to-day basis too. So you can recognise these sorts of changes as we described, and they're the sorts of things that can happen. So I think we've got a question here from Kate, who mentioned, how do you support someone's chronic pain when they have joint involvement from osteoarthritis and need a joint replacement, probably due to previous complications, is reluctant? So Kate, I assume that's in regards to they're reluctant to have the joint replacement itself. In regards to any sort of surgical approach, whether they had a fear, that sort of thing, that can be more of a psychological approach, that sort of thing, or what other interventional approaches are available from a chronic pain point of view, I guess.
And I think that somebody's coming up to a joint replacement. There's a big emphasis on them getting preparedness for that surgery. Putting that across in the way in which a patient understands it and how you actually say it. And I quite often say to patients, you know, if you don't use it, you lose it. So maintaining that activity, and someone that's got osteoarthritis, probably the worst thing that they can do is become inactive. So, and as we mentioned previously, that pain doesn't equal harm. The fact that it's hurting, it doesn't mean that you're hurting your tissue or you're hurting yourself, but it's a bit like a creaky door. The more you open and close it, the more freer it gets. And sometimes you've got to change the way that you actually speak to patients so that they understand that. And it might be like, pacing your activities. For an older person, it might be just simply that walk out to the letterbox 3 or 4 times a day where it's safe on flat grounds. But it starts off like walking down to the corner and do that until you're comfortable, and then go a little bit further. But it's continually to have those conversations and say, well, you know, what if you don't keep active, you're going to get stiffer. If you get stiffer, the pain's going to be worse. And if the pain becomes worse, you're going to want more medications, and it's just going to go round and round. It's having that conversation. Don't give up.
Yeah, and the activity side of things, I think, is an important thing too. You know, if they're indicating that they need the surgery per se, if they're reluctant to, but they continue to regress as a part of the vicious triangle or square that we were going through before, it's you're on a hiding to nothing. So do you either just have the surgery to engage with the rehab so you can get back to some sort of function, or what's the other pathways? And it's something to explore. I mean, for some patients, they may be reluctant and there's no convincing them otherwise, so be it. That's their personal choice, that's fine. As long as you're able to explain to the patient what all the options are and what they can do, that sort of thing, you can go from there. So, yeah. Sorry, we've got Kaylin as well, who said lots of excellent information. I like the message, giving confidence, helping turn down the volume. The brain has such a big effect on chronic pain. Absolutely. Yeah.
And having that discussion and using those tools, I have found to be the most valuable lessons. Print them off, put them down on the table, and talk to the patient, because we all know about managing pain. We all know about the guidelines. We do lots of training in those things. What we lack is the gap of that understanding and being able to translate that across to the patient so that the patient understands. You can't sit there and quote a guideline to a patient. They don't understand it. You have to put it in in those words that they understand and they get it. So, thanks for that question. It's a good one.
I think the other thing too is that from a practitioner point of view, I always find, and this is something that I talk to the pain specialists that work here at Pain Medicine, is engagement with practice nurses or nurse practitioners is always different compared to medical specialists or GP. Some patients are much more willing to open up to nursing staff compared to medical staff in regards to the what else and what other, especially if it's affecting parts of their life that either they've never talked about previously or never identified either. So
absolutely. And that's absolutely right. The nurses, we have our patients longer, and they'll sit down and they'll open up to us. They'll tell us things that they won't tell the doctor. So that's an advantage. That's very important. It's a really good point.
Yeah. So it's like I said, with the link pins for the practice, and it's something that if you can recognise and that sort of thing escalate to multidisciplinary team, you can really change lives. So yeah.
Okay.
Well, it seems like we've got a lot of people chiming in to say it was a really great presentation, very informative and very insightful, which I agree. Just want to take the time to thank Peter and Kathy again for your time this evening and for all the helpful information. We're nearly right on 7 o'clock, so unless there was any last questions that people want to send through, well, it looks like we've got one more just from Kate, which I'm not sure if you wanted to answer before we wrap up.
Increase of patients.
Yes, absolutely.
Widespread.
I mean, so if you want to talk about a pain condition that is...
You better read it out because they might not see it.
Oh, so does fibromyalgia increase the patient's sensitivity to pain? Absolutely it does. So fibromyalgia is one of those very poorly understood pain conditions and that's the sort of patients that we see quite often in our clinic as well, that once they either have a diagnosis of fibromyalgia or symptoms, signs and symptoms that are very similar to fibromyalgia, they often feel like they're the sorts of patients that have been pushed to the side or ignored, that sort of thing, but their pain is very real. What can you do about it? How can you manage it? What can they do as part of those sorts of strategies? When we see those patients in our clinic, we just talk about, you know, the multidisciplinary approach to pain, what you can do about it, and how you can manage it and control it. And the thing is, we never ever promise that we're going to cure your pain. That's one thing, we don't say the C word here, because you can never ever promise that pain is going to go completely. If it's able to get to a point where you can have some increased functional benefit, that's the biggest thing. So for patients with fibromyalgia, that sort of thing, and those sort of widespread generalized pain conditions, they're the ones that ultimately you may see a lot of in your practice as well, that may be on long-term opioids that may not be appropriate for their pain. And what can you get back to, and how can we help you?
And it's a bit like with fibromyalgia is having that discussion with someone. It's a bit like, again, translating that to how they can understand it. It's like having every light in your house turned on. Your pain is widespread, it's all over the place. But it's like, how do we go about trying to switch some of those lights off so that we can turn down that pain? So again, it's having that conversation in a way in which the patient understands it. So that's the task.
Well, it's a great question, because fibro is so poorly understood and essentially managed worldwide. So it's a great question, Kate. So thank you for that.
Okay. Well, I think that's all the questions that we've got through. So thank you once again for your time.
Thank you, everyone. Thank you, John.
Thank you for the opportunity to talk to a whole lot of practice nurses at once. Their value in the practices is so important.
If there's any other questions as well, John, I'll pass on my email, and if anyone wants to send me an email, I'm more than happy to go through it, that sort of thing, and we can go from there. So, yeah.
That's great. Okay. Well, thank you so much again, and I hope you all have an excellent evening, and thank you for joining the presentation.
Keep safe, everyone.
Thanks, guys. See you.
Bye.